everyone. Good evening and welcome to a new edition of the Indian Express Explained Live, our series of online explanatory conversations with domain experts and authorities on specific subjects. I am Munajit Majumdar, editor for explanatory journalism at the Indian Express. As some of you might be knowing, we have been doing these events for almost 6 years now. And I always begin with a few sentences about Explained itself, a section of the Indian Express that is very special to us. We think of Explained, the content in our paper and on our website, as well as in events such as this one, as being rooted in the news, but going beyond just the news. So it is context, it is background, it is connecting the dots, it is analysis. And in today's noisy news environment, an explanation of the news, why is something happening, what will happen from here on, how is it going to impact you, is perhaps as important as the news itself. This evening, we're talking about something that all of us have been talking about for 2 years now, COVID. But the pandemic today, as all of us know, is very different from what it was in March 2020, May 2021, or even a couple of months ago. The current third wave has been less painful, and it appears to be passing fairly rapidly. But there's still many questions. COVID is not over. And is Omicron going to be the last major variant that we will see? Or could there be more? Is it possible to predict how the virus will mutate in the future? Can we do anything to prevent future waves? To answer some of these questions, we have with us this evening Dr. Anurag Agarwal, Director of the CSIR Research Lab, the Institute of Genomics and Integrative Biology, an institution that is currently involved in generating the scientific information required to prepare the response measures for the pandemic. Dr. Agarwal, welcome to the Indian Express. Thank you for your time. We are very grateful to have you, sir.
Thank you,
Speaking to Dr. Agarwal will be my colleague, science editor of the Indian Express and resident editor of our edition in Pune, Amitabh Sinha. Amitabh has been writing almost every day on COVID since the beginning of the pandemic and has been tracking it very, very closely. We will also take a few questions from the audience. Today's Explained event is brought to you by our associate partner, Yojana IAS. My thanks to our partner, Amitabh.
Thank you, Manojit. Thanks a lot. Very warm welcome to everyone who has joined in. We hope you will find this discussion useful. And some of your questions, we hope will get answered during the course of this discussion. Dr. Anurag Agarwal, thanks a lot for agreeing to participate in this event. Thank you. Usually, I have a short presentation for an event like this to set up the context for the discussion. But I thought, this time, most of us, in the audience as well, everyone is very well aware of the kind of situation that we are in. So, without any further delay, I think it's better to just straight away get into the discussion. So I will start with a question that I think is uppermost on the minds of everyone, Dr. Agarwal. I'm not sure whether there is any very definitive answer to any of these, but I'll ask it in any case. So the question has two parts. One, of course, the first one is much more immediate. So when do you think is the third wave in India likely to end? And part two of this question is much more generic, is about, are we really in the end game of the pandemic? Thank you.
Thanks, Amitabh. Very, very important questions, both of them. The first one is easier to answer in a sense of the word. You know that India is a huge place. There is no one answer that fits all of India. But in the metro cities, like Delhi, Mumbai, in Mumbai, it's pretty much getting over. In Delhi, it is very much on the way down. I'm talking of new infections. In some cities like Bangalore, it is still possibly about to peak. And as you get out to tier 2 cities, some of them have already been affected. Some of them are yet to be affected. But as a nation, we are pretty much near the plateau around now. And very soon we will see it coming down. I temper these statements with the one important thing. What you look at are the known cases, and known cases always depend upon testing. Testing is not uniform across India because there are so many situations. So when it goes to the rural areas, obviously the testing is going to be less. So you will only see the decline. You may not see the plateau persist for a bit longer. So my own impression is that early February is probably when the true peak and decline would probably be starting all for India. But if you look at the counts, the decline will start anytime now. And coming to your second question, which is a tougher one, the end game question. I think the word end game has very different meanings for different people. So I'll clarify first what an end game means.
Yeah.
If in people's mind, end game means this is the end of COVID 19, well, that end game is not quite here. I'll explain why later.
Yeah.
But if what people mean by end game is that it's the time that our schools will reopen, it's a time that we will go back to near normal with relatively small and not very difficult precautions, I think the end game actually should have already started.
Okay.
To be very honest, I see no reason why we need to continue closing schools for much longer. And in the big cities, not all over India. And I think that part of the end game is already starting because that end game does not have to do with the end of COVID 19 in terms of SARS-CoV-2.
Right.
It has to do with the end of COVID 19 as a threatening disease that overwhelms our healthcare systems.
Yeah. But isn't it based on the assumption that we probably would not see any further disruption from another mutant, a future mutant that might appear on the horizon?
So, no, it is not based on the assumption at all, which is the
Okay.
reason I was separating those two things.
Yeah. Okay.
I think sometimes what we confuse with
Yeah.
is the virulence of a virus versus our own immunity and the combination thereof.
Right.
Just to illustrate this point, when the Spanish people invaded South America, many diseases, many viruses which were normal and not causing anything in Europe caused tremendous death in South America. Chickenpox killed many Native Americans in North America.
Yeah.
So, what we saw in the beginning was a virus to which almost nobody had immunity.
Right.
By the time we got the Delta, we had a variant that was a little bit more aggressive.
Yeah.
And a large population that was not yet immune.
Right.
And the herd effect got lost because there is nothing called herd immunity as the virus evolves.
Yeah.
So, what you should be counting is how many people are left who are still susceptible.
Yep.
We have seen again and again that once you're infected, once you've got 2 doses of vaccines, the likelihood of dying of the disease becomes much smaller.
Right.
So, as we come to Omicron today, we had tremendous amount of immunity from the big Delta wave that really created havoc around the country. On top of it, India had one of the largest vaccination programs in the world, with 90% of adults immunized by the time this really peaked.
Yeah.
And the combination gave us very good immunity that will protect us from death and disruption to the healthcare system.
Right.
That has now been further augmented with the Omicron wave spreading around the country.
Okay.
So going forward, the number of people at high risk of dying of COVID 19 will get so small that while future variants will indeed come, infections will indeed happen, healthcare systems will not get broken.
Okay. So now, before I come back to this, what you've said, what about the actual end game of the pandemic itself? Uh, is it something that is on the horizon? Is it something that will happen, or is it what a lot of people say uh, that we'll continue to live with this virus and that this will be endemic, like flu or any other disease that we live with, but we'll be able to manage, hopefully, with the development of therapeutics, which would be effective, uh, and with not much of danger of deaths and severe diseases happening. So, is that end game actually would it happen ever?
So, if I had to pick between the direction of smallpox, polio on one side, where there's a true end game, versus flu on the other side, where there is a continuing struggle, I will pick the direction of the flu.
Okay.
Because COVID 19 is not going to go away. it will very much stay. It will get less and less frequent, affecting only the immunosuppressed, only the unhealthy, only the severe high risk people, and the extremes of ages, very young children, very old people, as time passes. But otherwise, the destruction and difficulty it causes will become much less in time to come, until and unless the virus changes very significantly, which is always a possibility, but it's not a immediate high possibility.
Right. So it's very interesting what you say. What actually is the distinction between a disease like smallpox, which gets completely eradicated, or even polio to a very large extent, or almost extinct now, and on the other side, flu or a possible future for COVID-19, which just remains, refuses to go away. So, what is in the nature of the different pathogens which makes such a behavior possible?
So I'm going to take a little longer answer on this one.
Sure.
Basically, there are two parts to the equation.
Yeah.
The first is, will you get infected? And the second part is, will the infection become severe?
Right.
When we talk of a disease disappearing, we are saying the first step, we will not get infected, is correct. We have achieved that. Now, that can only happen if the virus is being blocked pretty much at the point of entry into the body, which typically means that as soon as the initial infection occurs, the virus gets neutralized either by things like antibodies, which can bind to the virus and activate it, because virus is inert until it enters a living cell. And if you can block it from prevent going from cell to cell, you can pretty much block the infection right there. The second is you very rapidly kill off even the very first few cells that get infected. Now, viruses are of various types. Some mutate a lot, some mutate a little. SARS-CoV-2 is not a virus that mutates a lot, but it is an RNA virus.
Right.
So while it mutates less than many other RNA viruses, it does mutate more than many DNA viruses.
Right.
And the other thing that has occurred is that the number of infections you have increases the probability of a mutation arising. So SARS-CoV-2 has that unique combination of being an RNA virus that has a natural tendency to mutate,
right,
and a large number of, if you think of human petri dishes, in which it is getting a chance to optimize itself. So that is the reason I don't think it's going to go the direction of smallpox or polio, which at any given point had a small reservoir. The last scientific point I will make on this is, to really eradicate something, it is important it does not have a host outside humans. At most, you will vaccinate humans, you will treat humans. You're not going to go find it in animals. Coronaviruses in general have lots of animal hosts. We have already seen with SARS-CoV-2, it has become optimized towards binding receptors of other animals. So it's going to find these animal reservoirs where it can keep evolving further.
It hasn't, till now, it hasn't happened, has it?
Yes, it has.
It has.
At least 2-3 examples exist. One was with minks. One is the origin itself. Let's call the origin part controversial. And let's not get into that.
Right.
In the phase it has already gone to humans in 2019 and onwards, already we have seen examples of going to minks. And we have seen examples of going to hamsters. We have now seen examples of, in fact, going to mice, dogs. So there have been multiple examples. So far what we have seen is human to animal. We have seen animal to animal. We have seen possible examples of animal to human, but the loop is almost certain to get completed. And that makes it difficult to eradicate such a virus. That's why flu keeps on circulating. Because, birds, pigs, animals, the flu recombines, comes back. That's the trouble.
So we already have examples of animal to human transmission with coronavirus, is it?
There are possible examples. It is very hard because, see, when a disease is circulating, it is hard to prove it's only from that animal that one got it, not from another human being. But there are suspicious cases for animal to human. There are plenty of cases of human to animal and animal to animal.
Right. Okay. So, at the start of the pandemic, or roughly at the start of the pandemic, we were told that the way this is going to end is when a very substantial proportion of the population gets immunity, either through natural infection or through vaccines. Now, over the last 2 years, in large number of countries, including India, a very large proportion of people have got the infection at least once, maybe 80 to 90%, or even more in India. Last July's Zero survey was 70% figure. So possibly 80 to 90% of the people have got it at least once. Also, in the last 1 year, we have seen vaccination with almost like 70% of the people getting both the doses, you know, of the vaccine. So both the conditions have been met, but the immunity has remained elusive, mainly because there is this immune escape capability that has, the virus has developed in subsequent mutants. So if that is the case, and what happened, you just now mentioned, the herd immunity is not something that probably you would have talked of. But what happens to the concept of herd immunity?
Okay. It's a really interesting question. In fact, I would argue there's been multiple temporary herd immunity phases,
Right.
just not a long lasting one. So, why did the Delta wave end in Delhi? It ended in Delhi because in our studies that were published last year, we found that almost 88% of our cohort of CSR employees got infected. When you start reaching 88% of the people getting infected who are unvaccinated, pretty much you get herd immunity to that particular variant, any derivatives. So you remember when Delta Plus came, there were a lot of fears of people something will occur. So we had been constantly maintaining the Delta Plus is too similar to Delta. And the herd immunity effect of a huge Delta recovery. I mean, I don't think any other country or city probably had 80 to 90% type zero positivity
that
we experienced here, which is good for us now, but that time was not good at all. So any Delta variant, our herd immunity would take care of.
Right.
Now, Omicron is a very heavily mutated derivative of the Beta variant from South Africa.
Right.
It is just not like Delta at all. And because it is not like Delta at all, any immunity, any antibodies you have will not bind and neutralize it. On the other side, the T cells, the part that takes care of severe disease, kills off the infected cells, will still remain effective. So if you lost about, let's say, 20 times lower or 40 times lower on the antibody, it was only about 50% loss on the T cell side. So severe disease got prevented, but not infection itself. So herd immunity is an infection concept, not the infection to severity.
Right.
What you hope for in herd immunity is you got a weak, vulnerable person, let's call an old, unimmunized person, not yet infected, and they're surrounded by this wall of people who are uninfectable.
Right.
That wall is the herd. And what happens with SARS-CoV-2 is it breaks through that wall. The wall is not severe, but it finds that person hiding behind the wall. That is what happens.
So it's almost, with Omicron at least, it's almost as if a new virus, a new pandemic has started, is it?
Well, I mean, in the context of literal use of the word new, it's a very different phase of the pandemic. Omicron is also significantly different from previous versions in terms of its lack of tendency to cause pneumonia in otherwise healthy people.
Right.
But it is not that it does not. There are plenty of children with pneumonia admitted even in Delhi right now. But the number is so small. See, I mean, we have also been desensitized by Delta. Under normal conditions, if 20 people were dying of a viral disease every day, the entire city would be wondering, oh my God. Right now, 70 cases in children, maybe 20 people dying a day in adults, especially the older ones. It feels like things are much, much better. Because what we were worried about was some maybe much larger number. So in that sense, it is not a new disease. In unvaccinated, uninfected people, like you're seeing in America, America is the best country to look at. Because America, despite having enough vaccines to vaccinate everybody, 25% of their population chooses not to be vaccinated. Because their population density is much lower than ours, there are many people still uninfected in many states of America. And you look at what Omicron is doing to America. I mean, the hospitalizations are through the roof. ICUs are full. I mean, not full like the Delta wave, but still, I mean, there is a load upon the system. So Indian experience is a combination of a weaker virus by about 80%,
Yep.
but also an immunity that gives you another 80% protection,
Right.
and then vaccination that gives you another 50% on top of it.
Yeah.
You combine 20% of 20% and then so on.
Yeah.
You end up with 2, 3, 4%
Yeah.
of the previous wave.
Right. And the thing that you mentioned about Delta plus and Delta, the fact that a large number of people had been infected with the Delta, and therefore, because Delta plus was not very different, so the immunity actually stuck. Or is that the same kind of case that we are likely to see with BA.1 and BA.2,
Yes.
which is being talked about now? So, because people have been infected with BA.1 of Omicron, BA.2 is unlikely to be very dangerous. Is that the case?
Absolutely. So only thing I would qualify is in India, BA.2 shot up very much in from the beginning itself.
Right.
So it might be a case of BA.2 protecting against BA.1 for many parts of the country. But if you look at South Africa, where everything was BA.1 until end of December. Now when BA.2 is going up, it's going up without causing any significant problems at all to them.
Right.
So yeah, same idea of similarity to each other, being protective.
So this sort of protection is very, the immunity that we have been talking about is very effective in similar kind of uh, mutants, but would not be very effective when a substantially mutated version reappears, say 6 months down the line, and that possibility cannot be ruled out, is it?
Yes, that is absolutely correct. That possibility can never be ruled out. So I would take it one step further from what you said. So today, ICMR, I think, has a paper out showing that Omicron can also protect against Delta.
Yeah.
There is an experimental paper out showing that Omicron does not protect against Delta. And the difference between two is that when you get an infection, not only do you build immune response to that infection, you also reactivate all your old cells that have seen previous versions of the virus.
Right.
So if you were to check people in India, and remember, India officially has only 25,000 cases per million, which means 2.5%, and our seropositivity is around 70.
Yeah.
So most of our cases are unknown. So if you take a blood of an Indian who has got Omicron infection, likely is that Indian has seen Delta also.
Yeah.
So after they get infected with Omicron, they will also make antibodies to what they saw previously.
Right.
So any study done in India, Omicron will look like it also neutralizes Delta.
Right.
You really need to find a person with very high quality studies, knowing they have never been exposed or infected, before you truly know the answer to this one. So you really would need a future variant that has not been seen by the Indian population to a large level before to create the next wave.
Yeah. Also, a lot of people, a lot of scientists have actually, called Omicron a natural vaccine, that it will protect you in the future. And in that context, a lot of people have said that this is probably the start of the end game. Some people have also drawn parallels to the 1918 Spanish flu, saying this is how things have ended because you have subsequent generations of mutants becoming weaker and weaker. Uh, you just now mentioned a little bit about the fact that the Omicron would be a helping agent along with vaccination and along with the natural immunity. Uh, is it a natural vaccine? How does it work?
No, I absolutely don't like that word at all. I'll explain to you why. The
Yeah.
first simple answer is just look at America, where there are unvaccinated, uninfected people, and look at what is happening over there. Number two, to call something a vaccine, the side effects must be very low comparable to vaccines.
Right.
So what do we expect from our current vaccines? We expect 1 in a lakh, 1 in 50,000, something to go wrong. Now let's take at what is the expected infection fatality rate. So Delta's IFR was somewhere around 2 in 1,000 after you adjust for all the unknown cases and so on.
Right.
And this is for generals. For older people, it could be as much as 1 in 100 as
Right.
well.
Yeah.
So what you find that Omicron is maybe 60 to 70% lower than that. In the age group below 5, for simple hospitalization risk, it is only about 50% lower. And many studies in UK and even South Africa show it might be only be 25% lower. And you realize that that is not a very, very safe thing. We are
Not
finding
an effective vaccine.
and we are thinking nothing much occurs because we have such a high immunity already.
Yeah.
When it is finding those unvaccinated people, it is still causing trouble. So Delhi is having 40 deaths a day, roughly. That's where we peaked. About half of them are with Omicron. About half of them are because of Omicron.
Right.
So with meaning you had something else, you just became positive.
Yeah.
Because meaning you came in with a proper viral illness suggestive of COVID. Already, I know of in one cohort that is running at least 100 cases in children,
Right.
with at least 16 kids in ICUs, 2 people on ventilators, 2 dead. If you had 20 people dying per day of vaccines, you would stop that vaccine.
Yeah.
And that's, I'm talking of a city. When you take it at a country level, it's much, much larger. So with vaccines, we are wanting to stop them if one person dies in a million. And here we are, if you want to speak of natural vaccines, not caring that in a city, 20 people are dying a day. It is terrible that, we had to have another variant, another outbreak. Infection is never a good path to immunity.
Right.
Surviving an infection is an excellent path to immunity, but you don't know that at the time you get it. And number two, long COVID. It has only been 1 month. We have no idea what's going to happen to the people who got even moderately severe disease. Doctors who might be listening to here today would know that all those idiopathic diseases, idiopathic in medicine means we don't know. Many of them occur after viral infections.
Yep.
Plenty of weird things occur to people who have recovered from significant viral infections. So let's not call it a vaccine at all.
Yeah. Since you mentioned, I thought I would have asked you later, but since you mentioned, if you can explain what exactly is long COVID, when people refer to long COVID, what exactly are they referring to?
Sure. So long COVID refers to when the immediate problem. See, COVID-19 is fundamentally a pneumonia. That's the way it came.
Yeah.
But it came with many other symptoms. Some people used to have severe headaches. Some people had fevers, joint pains, loss of smell, lung problems. After the immediate pneumonia goes away, many people continue experiencing a lot of symptoms. Even at the 1 year from the original severe infections, more than half the people in America, one big study, were reporting they were not fully back to normal. The typical things that people are complaining of course, those who got severe lung involvement continue to have some degree of lung issues. Another very common problem people are reporting is fatigue. Another one many people complain of is brain fog, inability to think, remember.
Right.
Then, of course, there have been complaints of people with rashes, joint pains, weird myalgias, which has mean body pains. And at least a few people that I know will simply say that, their fitness level doesn't come back. And these are good athletes who were very well. And all said and done, this is at least a few percent of all the infections. And that's again the reason, it is not a vaccine.
Yeah. So the long-term impacts, the health impacts of COVID, as of now, still not very well understood. That might be a long-term problem in a significant proportion of people, isn't it?
Oh, absolutely. And I really hope that, everything recovers, but our knowledge of viruses is such that viral infections in early life often lead to problems. So, for example, one of the biggest risk factors for asthma later in life used to be viral infections before the age of 5, particularly RSV or any other severe one. Now, we have no idea what, for example, Omicron, which goes to the upper airways more than lower airways, and creates viral infections in children, what it's going to do to their asthmatics down the line.
Right.
We have no idea where all. So when we know that Omicron changed the way it enters cells, and now no longer necessarily goes into deep lung as efficiently, but maybe going to a variety of places. My friends who are endocrinologists Talk about diabetes worsening after the Delta wave, and I don't know what will happen with Omicron. It's just too early to know, actually.
Yeah. So on the other thing, now when we talk about managing or living with COVID, uh, we are already seeing in the Omicron, the fear from Omicron is much less. uh, Also, there is a little bit of fatigue factor. People have got impatient, they have livelihoods to take care of, and they can't remain in isolation for a very long time. But also because of the fact that it is producing relatively milder disease, people are not so much afraid of Omicron. And uh, you know uh, the general refrain also is that let's get on with our lives, and even if we get infected, we are not going to suffer too much of a damage in any case. So with the Omicron, it probably is not a bad strategy, and people are going on with their lives. uh, is there any guarantee that a future variant would not be a Delta kind of a variant?
No, there is no guarantee. I mean, so first, I mean, fear is never a solution to anything.
Yeah.
Giving up going to school, giving up commerce, giving up going out has its own complications.
Right.
So you have to, look at the worst, the better of two evils.
Yeah.
And I would say if, the way Omicron is, the risk of death is small. Most people are vaccinated, immunity is high. Get on with lives. Open schools. That's one of the top on my list of priorities.
Right.
And commerce. I mean, that's really important as well, of course. And that has got nothing to do with saying that no worse variant will come. Maintain surveillance.
Yeah.
Maintain a high quality surveillance. When the next variant comes, detect it early. Take steps early. I mean, compliment South Africa.
Yeah.
The first sample was November 8th, November 9th.
9th.
By third week of November, WHO was informed. By the time we held the meeting, within 3 days of South Africa informing us, we called it a VOC.
Yep.
So act like that. Maintain good surveillance. React when you need to. Act as you need to. But meanwhile, don't go around with fear. There are always going to be viruses floating around, and any one of us can become victim to anything at any point. It's a low probability event.
A more dangerous event, a more dangerous variant is a low probability event.
So the virus will evolve for immune escape.
Right.
We know what the virus will do. The virus is currently, as this wave ends, going to find it difficult to propagate itself because immunity will be high. So which means the next mutation that will spread will be the one that allows us to escape the immunity.
Simple survivability kind of principle.
Simple survivability. In the process of acquiring the mutations that allow it to escape the immunity and spread further, what other changes will come are coincidence.
Right.
Usually there is a fitness cost, usually. And which is why there is this general thinking that over time, with sufficient immune pressure and vaccines, the virus becomes weaker.
Right.
However,
and you're talking about the fitness of the virus.
Yes.
Yep. Okay.
But ultimately, unfit viruses will never create breakouts. Ultimately, the only breakout that will come from the highly fit ones. It may be a low.
So they will be fit plus immune escaping.
Yeah. Yes. And their action upon humans is not really of any concern to the virus while evolving. Right. As long as it finds enough humans to spread to before the first one, something happens. The virus doesn't actually care that the human lives or dies. Yeah. And probability always goes in favor of our immunity protecting us and therefore preventing us from getting severe disease and dying. But if I had to bet on things, I would not bet on the virus. I would bet on working on human immunity with better vaccines.
Right. The Omicron wave, we have also seen a large number of children getting infected. It seems more than what we saw during the first and second waves. Is that accurate? And is there any other reason apart from the fact that children as a group who are unvaccinated and also a group that probably the virus, the mutations of the virus could be directed against, again because of that same survivability pressure?
That's a great point. I mean, so when you look across the world, it is the pediatric hospitalizations that have gone ahead of the adult ones. It has two reasons. One, of course, you addressed already. It is a less vaccinated group, and vaccines are important in preventing severe disease. The other part is if you look at the airways, this is going to the upper airways. Children have narrow upper airways. So the odds of getting, difficulty breathing, etc., when you are young will occur more towards very young children. And most of these are below 5. And in fact, within below 5, below 1. So that's the reason. In India, we haven't seen much so far, which could be because in India, the immunity was all around.
Yeah. And you spoke about surveillance and intelligence, and that is going to be key going forward. How good is our surveillance and intelligence infrastructure right now? Uh, with Delta, we were taken by surprise, and apparently we were not that good. In the last 1 year or so, how has our intelligence system grown? I would also ask you about the fact that the stated objective of INSACOG was to attempt at least 1% of sequencing of all the positive cases. Now with 3 lakh cases, that's not probably physically possible, so understandable. But even when we were down to say 10,000 cases, were we able to do say 1% of all the positive cases, a sequencing of all positive cases? So how good is our surveillance right now?
So that 1% point comes up often.
Yeah.
And my usual point to that is what India needs is smart surveillance, not brute surveillance.
Right.
If you look at South Africa discovered beta, informed UK, which helped them find alpha. The N501Y mutation was first noted by South Africa in their clusters, and then finally found Omicron within a month and notified WHO. They don't sequence a lot. They sequence very little compared to UK, for example.
Yeah.
But they sequence very smart, and their sequencing is very well integrated into cohorts, cluster finding, and a general epidemiology that is very strong. India should not get too obsessed with the number of 1%. In fact, we were reaching 1% in the middle. So it's not that the number was never reached. If you look at before the Omicron wave started, we were running around 1%. Okay. But 1% is not the point. The point is, when do you want to find a variant?
Right.
If that variant is causing a clusters and you are identifying the cluster and you are sequencing even half the cluster, or even if fraction of the cluster, if the cluster is being caused by the variant, you will find it even in 20 samples.
Yep.
Finding that cluster is important. And before it forms a cluster, you want to find it at, say, 1% level. To find something at 1% level, you need to sequence 1,000. If it is 1%, you will find it in 1,000. So those kinds of numbers need to be maintained. And the most important part, the worst time to sequence a lot is when an outbreak is going on. That is when things are not changing. It is the same variant.
Yeah.
It is that part in the middle when everybody becomes happy and thinks it's unimportant.
Right.
That is the time you need to continue sequencing. But at that time, nobody is interested.
Yeah.
We need to get over those big ups and downs and maintain a stable, good level of sequencing coupled with intelligence from the ground, clinical.
So are we doing it? I mean, the emergence of Delta happened at exactly the same kind of time that you're talking about, when things were sliding down, or were improving a lot, and the general thing was that it's already over, or the worst at least is over, and that's when it first emerged. Has the situation changed now? Is it completely drastically changed now?
So the big mistake at the time of Delta actually was that the variants we were thinking of were coming from outside, alpha, beta, gamma.
Yeah.
So everybody was looking at the airports as a source of, the next dangerous variant, not looking internally. So what Delta proved, I guess, was that every country must look both at its borders as well as inside. And by now, I think we are doing a fair job of it. Can we do better? Of course, we can do better. But if Delta were to occur again, I doubt, we may not match South Africa in terms of 3 weeks from beginning to complete data. I don't think our clinical cohorts are at that level, to be very honest. We don't maintain long cohort. Look, so how did South Africa find it? They found reinfections rising, in one of their cohorts. We don't have an equivalent cohort. Sequencing wise, we are probably doing more than them. But that coupling of the two levels of information needs to get better. It's already much better than it was. And periodic interactions led by the National Center for Disease Control and ICMR, along with sequencing, Ministry of Science and Technology arms, is leading to better exchange of information. But yes, there's always scope for improvement.
Yeah. So apart from sequencing, which is required in any case, what are the 2 or 3 things that we need to do, proactively, uh, to guard against future waves, or at least minimize the impacts of future waves? And I'm saying both, on side of government, and the scientific network, the laboratories, and also from the people, without whose cooperation, nothing is going to succeed in any case.
So let's break it into 3 levels. What do you want from the people?
Yeah.
You want a higher level of alertness, and at least when advice is given, with something simple like mask, etc., to follow it as much as that can be done.
Yeah.
And you also don't want panic. You want to follow the advice without panicking, and Japan would be the best example of any country that I can think of.
Yeah.
What you would want from the public health people on the ground, you would want good identification of clusters and rapid transport of samples to sequencing labs.
Yeah.
Because that gap can never be made up. You want the sequencing labs, of course, to have a rapid turnaround, and you want all the data to go into common platforms which are integrated so you can make sense of whether the new sequences are matching with something happening clinically, so you don't waste too much time. So we have something called the Integrated Health Information Portal now, IHIP. All sequencing data now goes into that. It also contains outcomes of patients. So already a big step has been made. And again, we will keep improving upon that. And of course, from the government, what you would really want is support at multiple levels to make sure the messaging is right and cooperation follows.
Right. And what are the few things that we now know about this pandemic, which we did not? I mean, at the start of the pandemic. So, what have we learned from this pandemic, which we can use to manage the pandemic in future? And how is it different? How is this particular pandemic different from every other potential pandemic? We never had anything of this scale, but the small outbreaks that we saw, which died out, H1N1, Zika virus. Uh, how is this one very different to what we have seen till now?
So there's always an element of luck. Sometimes it favors you, sometimes it doesn't. So if you look at SARS-CoV-1,
Yeah.
Why did SARS-CoV-1 not spread? One of the major mutant lines that came out of SARS-CoV-1 was actually less fit and did not spread further.
Right.
Even if you look at the beginning of the SARS-CoV-2 pandemic, one of the 2 initial lines that came would have died out. It never would have gone this far. The original mutation that nobody gives a name to because it is basically zero is something called D614G.
Yeah.
D614G mutation, if it had not occurred,
Yeah,
this pandemic would have taken a very different track. So D614G made it sweep across the globe. At that time, we didn't even have the concept of a VOC.
Yeah.
Nobody in the world was doing enough sequencing to know.
Yeah.
Then, after sweeping through the world, despite its low mutation rate, it kept on accumulating mutations simply because there were billions of people to get it. And then, of course, you get into this cycle where you have a fundamentally highly transmissible virus with air-based transmission. We could have recognized that earlier. That would have been much nicer.
Yep.
We could have focused more on masks and ventilation early. And then, of course, vaccine equity would have been nicer. So, assuming this virus came out of an unvaccinated person, Omicron, with a chronic infection, South Africa being more vaccinated would have been good. So, these are the things we learned. A, no country is safe till everyone is safe.
Yep.
Common sense measures remain as important as always, despite advanced science. And public messaging. remains as critical as ever. And many of the troubles UK, US, many other countries find themselves in right now
Yeah.
is because of very poor public messaging.
A question about vaccines. Whatever is available now and whatever is under development. Uh, so initially, we were told, you know, that this vaccines would prevent infection itself. Uh, that hasn't happened. Uh, then we have been told that it prevents against death and severe disease. That has happened quite well till now. And what hasn't happened is that we have seen a lot of breakthrough infections, and that has been one of the reasons also attributed for the rise in vaccine hesitancy, not so much in India, but in lots of other countries of the world. uh, how effective are the first generation vaccines? How important are they? And are these next generation of vaccines, the second or third generation vaccines, are they going to be qualitatively better, even at preventing infections? Or prevention of infection is not the job of the vaccines?
So an ideal vaccine both prevents infection and then by obviously if it prevents infection can also block severe disease.
Yeah.
An acceptable vaccine, not an ideal vaccine, an acceptable vaccine protects the individual who's vaccinated against severe disease. But then the target is universal vaccination
Right.
of all people at risk. So either is a good scenario. Universal vaccination with a vaccine that does not block infection but blocks death also accomplishes effectively the same thing, but does not provide herd immunity. So it is more efficient for society and for those people who refuse to get vaccinated if other people get vaccinated. So what SARS-CoV-2 is doing, it is making sure that only the people who recognize the value and benefit of vaccines and are willing to take it are getting protections. Others will get protection by the natural means, assuming they don't suffer consequences of that route.
Right.
And I would love to see better vaccines in the future, which could either be pan-Sarbeco, which means against all coronaviruses. There are work in progress, or vaccines that are not against a single ancestral sequence, but against a multiplicity of
Right.
possibilities, creating wide-ranging stuff.
Mm.
Now, from gain of function type experiments, the
Right.
equivalent here is that you let the virus grow in the presence of multiple antibodies,
Yep.
and you see which mutations allow the virus to grow out. And then you say these mutations are going to come again in the future. And you're already seeing what is called convergent evolution. Different parts of the world are producing the same mutations again and again.
Yeah.
At some point, you say 90% of the ways to escape the antibodies have been found. And you incorporate that into the next generation of vaccines, and you might be okay. And I think that's where we're going to go.
And the platform that is being used for vaccines, is there any inherent advantage or disadvantage with the platform, or does it matter, or the overall effectiveness is what matters?
No, there are definitely gains and losses with each platform. So let's start with the most old one, the inactivated vaccine.
Right.
Inactivated vaccines in
Which
general,
is like Bharat Biotech.
Bharat Biotech,
Yeah.
VLA.
Yeah.
In general, they will give you a diverse but not very strong immune response, and they will give you protection by the diversity.
Right.
But since, at least in this coronavirus, only the spike antibodies seem to be important,
Yeah.
it hasn't translated into any real major gains. I mean, every comparison, there has been no example that I know of where Covaxin did any significantly better than the others, not worse, not better.
Yeah.
The same. Disadvantage, another one with this is it's a weaker immune response. And although the adjuvant in Covaxin gives it a better cell-mediated immunity, but still, cell-mediated immunity is much smaller compared to, say, mRNA. Then we come to the viral vector vaccines. The viral vector vaccines,
like AstraZeneca,
Covishield,
yeah,
they are very good in the sense that they raise both cell-mediated immunity as well as antibody response to a higher level than the inactivated vaccines. Limitation, of course, is it's not the peak of either. And the side effect that you have seen with thrombosis occurring is something that has been seen with all the viral vectors. Again, not very high, maybe 1 in a lakh.
Yeah.
But young women still would not be optimal candidates for
Right.
this platform. Next platform, historically, the way we are speaking, would be protein subunits.
Yeah.
Very little data, only Novavax. Huge advantage, easy to make, easy to distribute, very cheap, easy to change because you only make a protein subunit. Less clinical data, but should be quite effective. In at least some trials, it's giving stronger responses than vectors.
Yeah. So that is coming to India in the next stage.
It's already come. I mean,
Yeah,
Corbevax, all are in India. They have also been approved. We just are waiting for the rolling out, I guess.
Yeah.
The last one, the mRNA platform, is a very interesting platform, very powerful immune response, stronger than I think anybody expected. But still difficulties in rolling it out at a country where the cold chain is not ideal.
Right.
They have very stringent requirements in terms of temperature of storage, delicate vaccines requiring a bit of high tech.
Yes.
So not suitable for the entire world, but India is coming up with its own mRNA vaccine with a company called Genova,
right,
which is expected to have less of these problems. So again, a great platform doing very well. I know there's some talk about mRNA gives you very short immunity.
Yeah.
But if you look at the UK data, they have, so here is the way I think of it. India, we have AstraZeneca and Covaxin.
Yeah.
UK has mRNA and AstraZeneca. Using the two countries' data, you can clearly do all the comparisons you want and infer the other things.
Yeah. Yeah.
And in the data coming out of the UK Health Security Agency, month after month, there has never been a point where mRNA has done worse than the vector vaccines.
Right.
They drop down both to the same level at 6 months. None has an advantage, but they stay at the same. It never crosses in the other direction. So I think all these platforms have practical and pragmatic advantages. For India, I think protein subunits, vector, and killed virus remain three of the very good platforms until we have the non-cold chain requiring mRNA.
Yeah.
I would personally be very happy, though, if at least for the cities, we did allow introductions in an open market.
Right. Right. Okay. So we will now open it up for our audiences to ask questions directly to you. Our first question would come from Anshum Verma. Anshum Verma, are you there?
Yes, sir, I'm there.
Yeah, please go ahead.
Sir, I have a question for sir. That the WHO has recently disclaimed that the vaccinated, whether you are vaccinated or not vaccinated, people will come in contact with the Omicron or the Corona. And also the global conditions are ideal for the new variants, as you have talked about. So I want you to further elaborate on the booster shots that which is going on, and how long and how many booster shots we would require, and also how can these prevent us from the upcoming variants.
A very good question, very interesting and complex one as well. So let me clarify always that from WHO point of view, it's a trade-off between global equity, where more people get vaccinated versus some people reduce the risks further. So the priority is always to get more people fully vaccinated before anything else. But now coming back to whether boosters work, plenty of data showing that the decline in protection against infection of both Covishield and mRNA, which in UK data went to between 0 and 30% for Omicron, goes up again to 60 to 70% against infection with a booster. So you would save about 40% of all infections, at least, whether 60% of all infections if you were to use boosters. But on the other hand, you will still see plenty of boosted people getting infected, creating the perception that maybe boosters don't work. On the more important side of severe disease, the gain is smaller. So even without a booster, the protection is around 70%, 65 to 70, UK data. With booster, it goes up to 75, 80. It also depends on which booster you use. So you get about 10% gain on that. So the way India interprets this data in terms of public health measures is that people who are highly exposed, like healthcare workers, people who are high risk, like elderly with comorbidities, are the ones who should be prioritized for such additional doses that we are referring to as precautionary doses, which is a sensible approach. If there is minimal benefit There is no point on giving it to everybody, especially given the fact, like I discussed earlier, that not all vaccines are exactly the same. So you need local data. And our context is also very different. Most Indians are infected plus vaccinated. So our immunity may already be pretty good. We may have already have equivalent of 3 doses of vaccines in terms of Western data. So this is what I see going forward, that countries will need to do their own studies to look at their own context. Now that Omicron has swept through the country, again, the immune response will be heavily boosted. So how frequently does India need to boost cannot come without Indian studies about immunity.
Right. The next question is from Jasojit Mukherjee. Jasojit, please go ahead.
Thank you. Firstly, Dr. Agarwal, I think is the best exposition of the pandemic I've heard so far, and I've heard several. So thank you for that. A simple question. Now, let's say people who are vaccinated, senior citizens, and who have got Omicron in this wave, how should we lead our lives? As a test case, I'm saying, for instance, my wife is immunocompromised. She's 65 years old. She just got Omicron. Can she go out, let's say, to a friend's place without a mask and have a meal? Or what should be the kind of risks you think we just sort of can take at this stage, especially in the context of the Delta, which you have touched on?
So the word that throws me off slightly here is immunocompromised, because that depends to what degree. But let's assume it is not severely immunocompromised. It is simply age comorbidity type of immunocompromised, in which case, after she is at Omicron, and I assume she was vaccinated because you appear to be knowledgeable on this. So given vaccination, given recent Omicron, her risk from further Omicron or Omicron derivatives is minimum. And given that she is in India and vaccinated, her risk from Delta is also minimum. These are the only variants out there for the time being. So yeah, she should go back to life as normal as possible. On the question of masks, I state the following. While mask wearing measures and advisories are in place, it is difficult for the government to distinguish between who has had it and who has not had it. So it is best for everybody to follow while in public closed spaces. But yes, in private life, one can easily go ahead without masks.
Actually, on that note, there is another related question, which I think a lot of people would have. So this is from Arvind Semwal, who is from Bombay, and he wants to know whether we should take any extra precautions while sending our children to school. The schools are going to reopen in Maharashtra, so should we be sending them?
Yes, that part is the easiest. I honestly think the risk to children, mental health, and development by not going to schools is far greater than their risk of having anything to do with COVID. In fact, I would argue, if I were to simply calculate, the risk of a child from COVID has always been not much greater than the risk of going to lay. So if you won't worry too much about that, then there is not reason to worry too much about this. The problem is, of course, what age are we talking about and the background comorbidity of this entire thing. So if the child is a normal child with no particular risks, and the vaccination policy will eventually get figured out. Like I said, it's very complicated in India because the Delta wave left even children infected. So we don't know the optimal vaccination policy for younger children. Please let them go to school. I don't think masks are going to be practical with children in schools for a long time. Older children could certainly make an attempt. So I would focus on ventilation. Good ventilation is a doable thing in India, and we are not yet in fully air conditioned closed spaces yet. So I would focus on that as the only thing to touch.
Right. Thank you. The next question is from Arvind Ansari. Please go ahead.
Yeah. Thank you, Dr. Anurag Agarwal. It was a very informative presentation, and I had sent a couple of questions, but you have answered. Now, my worry is I'm a sociologist, and I look at the deep sociological implications COVID-19 has made. You rightly mentioned mental health. So, my concern is that how are we going to negotiate the challenges, the health challenges which had been thrown up by COVID-19? And another thing also is the vaccination, because there is vaccine hesitancy, and probably the reason for vaccine hesitancy is that there are so many narratives going around, and the side effects also. So I would like to know that how are we going to negotiate these, because what you have told in your presentation also, people are having symptoms till 1 year, and I also was a COVID positive, and during Delta, my family. So my husband still is living with those conditions. There is lack of energy and fatigue. These are common problems, and even taste. There are some problems in the tongue also. So just want to know that our society, which is not that aware, and we don't have that mechanism also to educate them, how are we going to negotiate with knowing our health structure and health facilities we have?
I think you asked a wonderful question. I don't have great answers. I'll try to do the best I can. On vaccine hesitancy, India does not have much that I know of. And where it does, it's a bit of an issue of trust more than anything else. I would actually argue that globally it's always been about trust, that the government means well for you. So communities where you are seeing vaccine hesitancy tend to be the one where there is some degree of distrust of the system. So addressing that is probably the only way, and how one does that, you as a sociologist would probably know better than me. When it comes to behavioral change, I actually fully understand what you're saying. I'll be very honest. I mean, right now, if somebody is standing very close to me, it feels odd. And we used to, have that comfort levels earlier. So getting over some of our reactions now built in over 2 years will take time. For us, I think we can think about it and get over it as adults, so it's better. Important to emphasize that there is, a lot of mental health component. Children, I think we just allow them to be normal, and that's going to be very important going forward. But again, I would be very honest. I'm not a sociologist, and this is not my area of strength. So any statements I've made are with that limitation.
Right. Thank you. Thank you, ma'am. And I apologize for not calling your name properly. Her name is Arvinder Ansari and not Arvind Ansari. I'm sorry. I apologize. The next question is from Milan Mehta. Milan, please go ahead.
Thank you. Anuragji, my question is that still possibilities exist that, dangerous variants then Delta can come, isn't it? First. And secondly, don't you think that even vaccinated ones can be the source of a new variant? Because now the virus is identified what are the, vaccine inserted by the humankind in the system, and it has to fight. So that strategy can also be adapted by the variant, and more dangerous can appear. And if yes, what should the vaccine companies focus on? RNA, DNA spike, or what? Thanks a lot, sir.
No, important questions. Let me take the first one. If Delta were to come into this world again today, it would be something like Delta. It would be a much less severe illness compared to when it came. The severity is not always about the virus, it's also about the immunity. The immunity is much better. See, in Delta, if you look at the slums, there were very few deaths. The deaths during the Delta wave primarily occurred in the population that was previously protected in the previous waves. So it is something to realize that Delta was a problem where herd immunity broke down, and there were plenty of people who were neither vaccinated nor previously infected left to develop severe disease. At this point, this combination of neither vaccinated nor previously infected is so small in a country like India, and that's what I keep talking about also when I talk about hybrid immunity. India doesn't need to worry too much from variants that are not completely different from what has come so far. Now, coming to your point about vaccination promoting variants. Now, that is something I hear a lot. It is untrue. The most important thing for generation of a variant is infection. If on the average, vaccines reduce infections, even if by 50%, and they reduce the duration of infection again by 50%, they have already cut down the amount of time the virus spends in the human bodies mutating by a lot. And this is something that people are not realizing. So there's actually a study done. Can't cite the reference to you immediately. They have looked at the impact of vaccination on viral diversity, and they found that viral diversity was coming more from unvaccinated communities than the vaccinated one. Because if you don't do vaccination, you'll get natural immunity. The virus will put under the same pressure. So no matter which way you come, the immunity by the human body will put pressure on the virus, which is why every virus mutates, including HIV, including influenza. There is no example to the contrary.
Right. Next question is from Sarang Pitadewad. Sarang, please go ahead.
Yes, sir. I'm audible.
Yes, please.
Yeah. Good evening, sir. Myself, a student from class 10th.
Yes.
Actually, I have a different question. Due to this pandemic, even now also our schools and colleges are shut down. And sir, as a student, personally, I think that lockdown is not the option every time. We need to come outside the door and take the risk. What is your opinion on such lockdown, night curfews, and restrictions? Do this really helps us to overcome? Thank you, team, for giving me such opportunity.
Thank you, Sarang, for asking that question. I am totally in favor of what you said, which is that we must maintain schools at one of the higher priorities. So when I see many other things getting higher priorities over schools, I'm always disappointed. Particularly where school can be done outdoors or with open windows, the risk is actually small. It is not touch, but rather air that is the main source of rapid transmissions. And I think India was actually better placed for staying open compared to many of the countries where everything is closed and air conditioned. So, yes, I think going forward, now that our country is vaccinated, now that our immunity levels are high, we should almost never close schools until absolutely essential to do so.
Right. There's another question that I'll read out. This is from Dharmendra Kapoor, and this was a question that used to be asked very often during the first wave about surface transmission of the virus. So Mr. Kapoor wants to know whether spraying surfaces with sodium hypochlorite does it help in preventing the transmission? And he says he's very worried about the lifts in particular.
So it's a matter of opinion and data combination. My net synthesis is it doesn't. Hand washing does remain important, however. So before your fingers touch your nose and mouth, if they are washed, if they've been in contact with things, it's a good thing. Trying to decontaminate surfaces is possibly useful in a hospital ward where there's a huge burden of infections. Not important otherwise.
Right. Thank you. So the last question is coming from Anona Dutt.
Sure.
Anona, I must disclose, she's the colleague of mine at the Indian Express.
I know Anona quite well.
Yeah. So Anona, please go ahead. Yeah.
Anona seems to.
Are you there?
Hello. Yes.
Hi, Anona. Go ahead.
Good evening, sir. So we were talking about a lot of different kinds of vaccines and, people now having hybrid immunity. I just wanted to understand whether there is a possibility of antibody-dependent enhancement with any of the new variants.
Great question. And for others, let me clarify what Anona means, is that in diseases like dengue, people find that having antibodies which are not effective enough to neutralize the virus, but can bind the virus, actually makes disease worse. The first time you get dengue is usually not when you get the severe hemorrhagic disease. It's the second time, because ineffective antibodies contribute to the disease. So that was always a worry when we started looking at this particular virus. Part of it depends on where the virus goes and which cell reacts. Respiratory cells are always less likely to cause it compared to macrophages. So that was number one, that ADE will be unlikely. Number two is significant amount of experience by now, including with multiple variants that made neutralization ineffective, but still antibody bound. And we haven't seen it yet. So going forward, no reason to think that ADE will be a major problem, but we will always keep a watch out for it.
Thank you. So that should bring us to the end of this discussion. Thank you so much, Dr. Agarwal, for patiently answering all the questions. I am sure people found it useful. Everyone who joined in, Thank you so much for joining in this discussion and for asking questions. I hope you got your answers. I hope it was useful to you. A special thanks also to our partners, Yojana IAS, who have made this event possible. Thanks to them as well. Thank you all. Thank you for joining. Thanks.
Thank you, everyone. Bye-bye.
Yojana IAS offering fresh batches for the year of 2022 and 2023. Yojana IAS has excellence journey of more than 20 years with highly qualified and experienced faculties, online interactive classes, mock tests, doubt classes, mock interviews, answer writing sessions. Yojana IAS offers a complete package for the UPSC aspirants. Yojana IAS के ऑफलाइन और ऑनलाइन बैचेस इंग्लिश और हिंदी दोनों ही मीडियम में अवेलेबल हैं. So what are you waiting for? Go to our website and register yourself now. Yojana IAS offering fresh batches for the year of 2022 and 2023. Yojana IAS has excellence journey of more than 20 years with highly qualified and experienced faculties, online interactive classes, mock tests, doubt classes, mock interviews, answer writing sessions. Yojana IAS offers a complete package for the UPSC aspirants. Yojana IAS के ऑफलाइन और ऑनलाइन बैचेस इंग्लिश और हिंदी दोनों ही मीडियम में अवेलेबल हैं. So what are